Top Med Talk.
Okay, hi, I'm Monty, Mythen, Editor-in-Chief of Top Med Talk, coming to you live from EdPom 2019 here at the British Museum in London. Early in the morning, first cup of coffee, the beginning of the day. We're about to go live on stage at 9 o'clock. There's an interesting first quick-fire session, which includes me opening, talking about the International Board of Peri-Operative Medicine. Now, I've been lucky enough to collar two friends and colleagues from UCL who happen to be occupying the real estate next door to us here in the trade exhibition at the British Museum downstairs, if you want to come say hi to us. And that is Professor David Walker and Dr. Robert Stevens. David, Professor of Interesting Stuff at UCL. How did they manage to make you a professor?
Yeah, early in the morning, I wonder that myself. But indeed, that's my title, and we're busy trying to walk the walk on the shop floor this morning after a couple of days of great activity.
David, education is your big thing. I mean, we're all into education at UCL. I should back up on that one. We're here for our students.
Okay,
honestly.
I just met one this morning.
You did. A medical student over here working on the coffee bar over here said, "Oh, you're Rob Stevens." So we should introduce Rob in a second as well.
It's true.
You can't go anywhere these days.
So David, give us your official title at UCL then.
I guess I am the Peri-Operative Medicine Professor of Education.
Professor of Education. Rob, you've got a new title at UCL.
I'm head of clinical and professional practice for the medical school.
Excellent. Yeah. Congratulations.
Thank you very much.
So that's why that young lady...
She knows. That's
you're
right.
the only... There's no way she'd recognise the professors. I should point out I'm a professor at UCL as well, allegedly. Yeah. But she noticed you.
She did.
How was she able to face check you?
So it's really great because at UCL we've now managed to start teaching the year 1s, year 3s, year 4s and year 6s. So we're starting to move into... teaching the young students some physiology, some transferable skills, bit of communication, some sort of harder science like blood gases. And myself and Jane Lowry, who's one of my colleagues at the Royal Free, do a sort of feedback lecture, 2 or 3 hour summary lecture, trying to pull things from the clinical time and sort of show them what the point is of their physiology they're learning.
Excellent. Physiona, you're wearing a fantastic T-shirt.
I am, thank you much.
I think I recognise, is that Carl Wasserman's diagram from the legendary book about cardiopulmonary exercise testing?
Yep, and it's from Carl Wasserman's course, which I went to.
Oh, well done you. So it's 3 cogs representing muscle, circulation and ventilation. For those of you who are into CPET, see if we can get a picture of it to put up at the front of that.
Yeah, picture right now.
Get a picture of it right now. It is a legendary photograph that summarises why cardiopulmonary exercise testing is interesting, useful, and primary physiology.
Smile.
Yeah, smile. We'll get that up on front of the podcast. So David, you and your team, legend at UCL for producing one of the most popular MSc courses at UCL ever on Peri-Operative Medicine. Tell us that little story quickly.
Oh, well, I guess we just rose to the challenge or spotted a chink in the armour for online learning, Monty. Yeah. So we could extend our reach beyond UCL and get to the world. I guess that's what we've done. 5 continents, 129 countries, all through the power of the internet, really. So,
and how many people have registered to do the MSc so far? I know that whether they complete it or not is a complicated equation, but you can give us the primary metric, which is how many people signed up.
Yeah, well, the answer to that is 300.
Wow.
You'd think that if it was online, you could have thousands, but actually it doesn't work like that because someone has to mark the papers, somebody has to set the exams.
Yeah.
So actually 300 is still a big volume of volume of students.
And we've had a number of people through here who have been telling us that they're doing the master's program and how much they've been enjoying it and how highly they value it.
Yeah, I think we've noticed a difference this year. People coming up to the stand and actually getting into the detail. Before it was a cursorily give us a flyer and we'd go away with that. But now they're coming up, they want to do the detail. What is this frailty thing? How many learning hours do I get from X, Y, and Z? So I think we've arrived, really. Yeah.
So in total, how many hours of learning do you have to do?
Well, don't forget, Monty, it's notional learning hours.
Okay.
So it's not sitting in front of a computer for 1,800 hours. And
wow. Is that the total?
Yeah, that's the total. But, these...
that's incredible value for money.
I think so, Monty. Thank you for that. Yeah.
So in total, and you can do that in a year or spread it over a number of years?
Yeah, we can. It's called flexible learning, flexible being 1 to 5 years. Most of our students from our metrics tell us that they do it over about 3 years.
Okay.
Because most people are in full-time employment.
And it's staged that you can get certificates and diplomas en route. So you can knock, if you do over 3 years, you can knock something off every year.
You bet.
You can have a party every year.
You can have a party every year and a certificate every year.
Wow.
It's a win-win on our course. Yeah.
Now, quite a lot of people do let's call it the teaser. There's this MOOC thing. What's a MOOC?
Yeah. Well, the MOOC comes from our same stable. The MOOC, again, is an online course which joins up a community of learners across the globe. And it is indeed that. It's a taster. It's a dip into what is perioperative medicine, what are the fundamentals of perioperative medicine, and asks a lot of questions that people may want to delve in and find the answer to.
And what does MOOC stand for again?
Massive Open Online Course. So the massive means that it's open-ended. Thousands. In fact, we have on our last course about 18,000 students.
That's so cool.
Excellent. Now, I'm joined by the managing editor-in-chief of Top Med Talk and the lead anchor in the USA, by Desiree Chappell.
Do you remember my name?
Do you remember your name? It's because you usually do the introducing.
I usually do.
It's easy for me to just say hello. You usually do all the hard work.
Hello, Monty.
From Louisville, we can all practice saying that, Kentucky, in the USA.
Hi, Monty.
So I know you're going to have got some questions for David about the MOOC in particular and then the MSc. Have you done the MOOC yet? Have you had a look at it?
So I think the problem with the MOOC is that the beauty of it, but the problem for me is that instead of trying to do it in the 4 weeks and just doing it for free, I went ahead and just paid for the certificate. So now I have all the time in the world to do it, and I just haven't sat down to finish it. So I started it, but I haven't finished it yet. The MOOC.
Yeah. And the MOOC's 16 hours, is it?
It's not
12.
a ton. 12.
3, 3, 3, 4, 3.
Yeah.
Wow.
Yeah.
So I need to do it because I think it's amazing. I love it. I think it's it is a great teaser, and it's made me seriously think about the master's program. I mean, honestly, even though time-wise, I don't know if I could actually do
We'll
it.
talk more.
I know. But it's fantastic. We talked to Sam Bampo the other day about the master's program and telling us a little bit more about it. I think that one point or a couple points about it, it's multidisciplinary. So anyone can take it. You don't have to be a physician.
Absolutely. And we've got nurses, pharmacists. We've even got a couple of industry colleagues involved. Physiotherapists. Yeah, across the piece, really.
Yeah.
I suspect mainly physicians, but actually a lot of nursing representation too. Yeah.
Yeah, that's what Sam was saying. It was represented. And the other point is that you can just literally do it anytime that you want to.
And from anywhere.
And anyway, the international aspect.
I mean, that was big for us, and I hear you beating yourself up about not finishing the course. But actually, we shouldn't do that. Online courses are, by their definition, pick up, put down. And that's the beauty of it. You will get round to finishing when it suits you. Yeah,
that is the beauty of it for sure. And I think type A personalities, we have to just kind of get used to the online thing because you're so used to doing everything.
Deadlines.
Gotta have it. Yes,
deadlines.
Exactly.
I mean, we sort of tossed around, didn't we, Dave, with thinking about should we have a more conventional structure in terms of getting people through on deadlines. But we ultimately sort of went away from that because of the benefits.
Free 4 weeks part, though? That is, you have to complete it in that time, don't you?
So I think the MOOC you have to complete in 6 weeks.
Yeah.
And we recommend, Abby Whiteman, who really leads it, recommends you try and do 3 hours a week if you can.
Yeah.
Partly because you're going through and then interacting with other people on the course. And that's really nice.
It is. Yeah.
And how many people have done the MOOC so far, roughly?
We're probably close to 20,000, certainly over 19,000.
Wow.
Yeah.
That's really
so that's in 129 countries and soon to be 140 countries.
I know what I was going to ask. Do you translate any of the content?
So the MOOC has been translated to Spanish. We didn't actually translate the audio of the film, but there's transcripts.
Yeah.
So it's in Spanish as well for Spanish speaking.
Because we had a good... Evan Karash was here yesterday, the editor-in-chief of Anaesthesiology. Excuse me for a second. Talking their translation into numerous different languages. I think you might have a chat with him about how he's achieved that with his various different networks. Maybe be able to chip in. I'm not promising he'll do that. But I think he's done Spanish, Portuguese, Mandarin, French in particular we were talking about. The reason French was because of Francophonic Africa. Because there's a big swathe of Africa that doesn't get picked up. So we might want to push the French up the chain a little bit. We've got some good French speakers in the department.
Yep.
We could do that, and the Spanish translation instantly got us to South America, and that was fantastic.
Absolutely.
Overnight the numbers went through the roof. That's great.
Portuguese. You're going to do some Mandarin or whatever. Chinese.
Yeah. It's labour intensive, but we should be looking at that, and
Absolutely.
I think probably we will be.
Next steps there.
Now, Rob, you've been heavily involved in the MSc, the MOOC, etc., but the medical students are your big baby.
Yeah, that's right. I mean, I think in a way, as anaesthesiologists, it's a sort of open door to go into the medical school because we're uniquely suited to teach medical students. I mean, we're naturally good communicators. We sort of collaborate. Our sort of structure is quite horizontal. We don't tell people what to do. We're used to one-to-one teaching. And, of course, we are physiology, drug, 30 seconds, dramatic physiological change.
Yeah.
So there's so much we can bring there. And there's a lot of us. There's huge numbers of us, where there's a lot of anaesthetists.
And there's sort of a push at UCL, which you've been a part of driving, to sort of build surgical training around a spine of perioperative medicine.
Yeah, that's
so perioperative medicine is the core of what you need to learn as a doctor. And then the fact that it dips into certain surgical procedures is now deemed to be a bit more of a secondary issue.
It is. I would say, though, that probably the traditional silos are still present, Monty.
Okay.
I mean, that is the dream that you've just sort of highlighted. And I think many medical schools have got that. People who've totally redesigned the curriculum relatively recently have got your idea of sort of a perioperative block. You do some surgery, you do critical care, you do acute care. Some people have even got airway surgeons teaching airway anatomy combined with, anaesthesia, sort of anatomy, if you like. So
still really hard to get into medical school in the UK, yet we have a shortfall of doctors. What's that all about, Rob? Probably not your fault.
I don't think it is my fault. No, I think you're right. That's about workforce planning, isn't it? Which I am not part of yet. That's.
So where do you stand on the alternative providers? So Desiree is a nurse anaesthetist.
Yeah, I know. That's right. I know.
Which I think the history of that in the USA came out of a manpower crisis back in the day, in the 60s or so, was that?
No, actually, I think, the stories that I've heard is that we nurses were doing anesthesia long before, actually, like during the civil, long time ago. And then
you didn't have the doctor busy doing other stuff.
Exactly. Yeah. And then it kind of became, it's kind of fluctuated up and down, I think.
Now, I think we've reached a tipping point in the UK where we are fully embracing non-clinician providers to do a lot of the burgeoning quantity of work that's coming through, in my opinion, quite rightly. We have some colleagues in our department who are not physician trained, who are excellent anaesthetists.
Correct. No, correct. They are.
You're going to see that. Is that going to grow, David? I know you've been trying to sort out a training program.
Yeah. Well, if the editor of BJA is listening, I sent him a letter this week.
You'll have it back soon.
That on the back of Health Education England's report for workforce planning, which I think is a moderately limp document, but I thought it was a great opportunity for the college to embrace PAA training, or AA training as it's now called.
PAA and AA being?
Anaesthetic associates, whereas once they were physician associates in anaesthesia, and they come under this umbrella group, MAPs, medical associate practitioners.
So they made that transition from physician assistant anaesthesia to anaesthesia associates. In other words, the elements of independence are growing there.
Yeah, absolutely. And there's nothing to fear there. We need a blended workforce, and it will give us, as anaesthesiologists, a greater independence and a greater freedom to bring our expertise to the shop floor, I think.
Yeah. Monty and I talk about this frequently, and that you guys are kind of sticking with more the framework of a PA type or anesthesia associate and not necessarily nurses, because you don't want to pull from your nursing workforce. I honestly think that's happening a lot in the U.S.
Yeah.
As they're pulling away from our critical care nurses they're being pulled into nurse anesthesia, and it's leaving a real crisis in critical care for.
We don't have enough docs.
Nurses.
We don't have enough nurses. We don't have enough of almost everyone. So pulling from the existing pools is not going to work.
Yeah, it's kind of tough.
I of course agree with that, Monty, but I don't think we should shy away from the fact
I don't think
that
you should
people
limit that either.
who want to do other things express themselves, for goodness sake.
Well, I mean, I've been fortunate, and I'm so glad that I was able to go into anesthesia. I love it. I mean, I loved nursing, but this is my place, and I'm glad I had the opportunity. And I think for a lot of people, as a nurse, there are sometimes you want to work your way into other things and work your way up, and that's a natural step for critical care nurses for
Desiree,
sure.
how long have you been a practitioner now, a fully fledged practitioner?
About 11 years.
Obviously, you don't look old enough for that. We should point that out there.
Yeah.
Very good, Monty.
Wow, you're making up for other.
But moving on rapidly, you do everything, don't you?
Yeah.
Yeah. So you do cardiac, for example.
Mm-hmm. Yep. Do
so
hearts.
no boundaries to practice.
No,
Nope.
there are the limitations on our scope of practice are pretty much. I mean, we can do everything. Right now, nurse anesthetists are training to do echocardiography, but TEEs in the OR. But we most of the time don't do
But
those.
shock horror probe, you can intubate somebody, put a central line, put an arterial line, float a Swan-Ganz catheter, without having been to medical school. I'm not quite sure how that works out. But.
I guess in a way that is partly the threat, and I'm putting that in inverted commas, isn't it? Well, that's the question. Why would you want to go through a medical school then? One might say, if you can do that without.
But the thing is, I mean, to the point, I mean, in the U.S., there are a lot of nurse anesthetists that can practice completely independently, and they do practice in solo practice. A lot of that happens in rural areas. It can happen in more urban areas. The practice where I've been the last 12 years was very collaborative. We worked in an anesthesia care team model, so it was nurses and physicians. I think sometimes the level of supervision could change a little bit, but, I mean, it was a collaborative effort. And in the heart room, it wasn't just me all the time. I mean, I did a lot on my own. But if there were ever cases where we needed, I needed more help, more expertise, someone that's been doing it for longer, do the T. I mean, it was very collaborative. And it was, always a great working relationship. And I think it can work like that.
And I think everyone recognises that there are physicianly components of the provision of being a provider in an anaesthesia care team, in the same way that there are sometimes nursing skills that are brought to bear that are different, overlapping circles. But it's a care team almost everywhere, isn't it?
Yeah.
That's the predominant model.
And these things are interlinked, Monty. If the vision is perioperative medicine, I don't think we're going to deliver perioperative medicine if the consultant anaesthetic body are standing in an anaesthetic room welded to an anaesthetic machine. I think we have to be overarching, and we have to be working where the work is.
Yeah, I agree. I mean, I think that there's in perioperative medicine or perioperative care, I think there's a huge opportunity for the collaborative teamwork, and I think that whether it's in the OR, whether it's in critical care, or wherever it is, there is a need for advanced practice providers and providers that are trained at whatever level they are, and it can work really well and actually benefit the patient and benefit everyone.
And slightly off piece, Monty and I have a colleague who was a ITU nurse, a research nurse, and is now a manager. So I would also quite like sort of AAs to sort of move through that potentially into sort of move up the ceiling if they want to, or break the ceiling to other ways of influencing practice.
So last couple of minutes, guys. What's over the horizon? What's coming next? Rob, education? What are you going to do?
Our full integrated BSc. I think we're going to just have more sort of, from a UCL side, going to have more people just moving into UCL teaching a load of other things. So sort of communication, patient safety, and things like that.
So an integrated BSc, to remind people, is medical students take a year out do knock off another degree in a year.
Right. And so they do the first 2 years preclinical.
And the new one is going to be?
In probably acute and extreme physiology.
Okay, so building on, because before there's been the CASE, the Centre for Altitude Space Extreme Environment Medicine integrated BSc, which has been extremely popular at UCL as well, with the Everest gang, etc. So you're building on that. So that's one of your next big projects. If I'm going to get into teaching at UCL, the medical students, do I come and see you, Rob?
Yeah, Google UCL Stevens.
Say it again.
UCL Stevens.
And actually, you did a great podcast with Joff last year at the ASA. Oh, I loved it. I've listened to it multiple times. So be sure to check that out. You can search Rob Stevens in the search function and listen.
Yeah, and come and join us at UCL. All you have to do is fill the paperwork in online, send your application in.
Can I get a job there, guys?
Yeah, sure.
There's always a job for you, Desiree.
David, over your horizon?
It's getting into the CPD space in a stronger way.
And that's for our non-European listeners, CPDs.
Yeah, so professional education.
Yeah,
professional
CMEs.
practice. CME, indeed. There's a great market if we think about it like that, but actually there's a great need to educate people in perioperative medicine. And it isn't all about credit-bearing MSCs or free courses. There is a panoply of things that we're not developing and should be developing, and I think next year will be all about reaching out to that group.
That's awesome.
So for those of you listening who want to come to the Top Med Talk Zone today as we're here, what we've done is we set up a number of different screens. We're using sort of silent disco, silent opera technology so that people in the trade exhibition can listen into our conversation. There's a mass of people listening to us talking at the moment. And if not, you can switch to different screens. There's some movies running about physiology in particular. We're being sponsored by Edwards Life Sciences. Today we're going to be discussing a lot about blood pressure, hemodynamics, goal-directed therapy, and in particular we're going to be discussing artificial intelligence, machine learning, and the use of so-called HBI, this predictive indices that are now clinically available that in the operating room and critical care environment predict that patients are going to become hypotensive. We're also going to touch on closed-loop technology, including the idea that the computers might be better at it than we are. Ooh. Is that? What do you think about that, Rob? Scary? Scary. Well, we'll talk about that later on. Yeah. Guys, thank you very much indeed for joining us. Desiree, do you want to do a little wrap there?
Oh, yeah. Thanks for joining us. Be sure to catch us on all of our social media platforms, Twitter, LinkedIn, Facebook. We're going to be doing a lot of tweeting today, so check us out. Tag us if you want. And thank you for listening.
Brilliant.
Cool. Thanks, guys.
Cheers.
Thanks, enjoyed it.
Thanks,
everyone.
everyone.
Top Med Talk.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.